My name is Dr. Susana Banerjee. I'm a consultant medical oncologist at the Royal Marsden NHS Foundation Trust and a reader in women's cancers at the Institute of Cancer Research. And thank you for the opportunity of inviting me to the 8th National Annual Conference. I only wish that I could be with you in person, and I hope that one day soon that will be possible. In fact, my last trip before the whole COVID situation was to Kolkata. So I look forward to returning to India. So I'm here to talk about endometrial cancer, changing the guard with targeted systemic options and immunotherapy. So here are my disclosures, and as some of you will know, that I serve as Director of Membership for the European Society of Medical Oncology, ESMO. So in the next 15 minutes, I'm going to provide a real high-level overview and signpost you to some of the key publications that are very exciting, looking at the advances in targeted treatments and immunotherapy where we stand right now in endometrial cancer. So I'll briefly cover molecular profiling, some targeted therapy approaches of interest, for example, HER2 and CDK4/6 inhibitors, immunotherapy, which is changing and changed the face of treatment of cancers, and now changing the treatment of women with endometrial cancer. So looking at PD-1, PD-L1 inhibitor monotherapy, and also combination therapy, so namely Lenvatinib with Pembalizumab. So let's remind ourselves that recurrent advanced endometrial cancer remains the 6th most common diagnosed cancer in women globally. There are 417,000 new cases and 97,000 deaths in 2020. And it is the most common cancer affecting women in developed countries. The incidence and the prevalence is rising globally, and so it's an issue for all countries. Until recently, there have been limited treatment options for recurrent or advanced disease. So what we have is hormonal therapy, for example, tamoxifen, medroxyprogesterone, chemotherapy, carboplatin and paclitaxel, and no standard of care for second-line therapy, so beyond platinum-based chemotherapy. So treatments that we use in practice include anthracycline, so doxorubicin, paclitaxel again, hormonal therapy, and re-challenging with platinum. So we have learnt a lot from the scientists and translational researchers working on the molecular profiling of endometrial cancer. And it is recognized that endometrial cancer is not one disease. We've been used to treating and continue to do so, treat endometrial cancer according to histological subtype. But we know from the TZGA that there are molecular groups categorized by these surrogate markers. So this is a slide summarizing molecular class 1, 2, 3, and 4. So the POLE mutated, the MMR deficient, the non-specific molecular phenotype, NSMP, and the P53 aberrant cancers. So there's an opportunity here to tailor treatment and a role for immunotherapy. So data from the PORTEC-3 trial showed that the molecular classification is both prognostic and has predictive value of benefit in early stage endometrial cancer and the role of adjuvant chemotherapy. It really raises some questions about the need for adjuvant treatment, for example, in the POLE mutated group. What about the P53 aberrant group, potentially PARP inhibitors, and the MMR deficient group, immunotherapy? And what do we do with patients in the NSMP group, potentially hormonal treatment or other targeted therapies? What we know is that the POLE mutated group of women do not relapse compared to other groups, regardless of treatment. And the P53 aberrant group has the worst prognosis, but also the greatest benefit from adjuvant chemotherapy. And as for the MSI and NSMP groups, well, this is intermediate prognosis, but little benefit from adjuvant chemotherapy. So moving on to the potential therapeutic impact, well, recognizing these groups, here's another way of dividing the groups according to copy number as well as microsatellite instability status. there are key characteristics, key mutations that have been noted in the molecular profile, and perhaps we can target these within clinical trials and then hopefully changing practice. For example, ARID1A mutations are relatively common in some of the subtypes of endometrial cancer, and KRAS mutations. So potential drugs include targeting the PI3 kinase pathway, HER2, immunotherapy, FGFR receptor, WEE1 pathway inhibitors. And so there's a host of clinical trials in development looking at this. So now what I'm going to talk about are the results of one such trial. This was the ENGOT, which is the European Network of Gynecology Trials, led by the Nordic group called the Paleo Trial. And this was presented at ESMO in 2020. And this was an academic study in patients with endometrial cancer. They had one prior systemic therapy, had endometrioid histology, and no prior endocrine therapy except for progestins. And patients received either letrozole and placebo or palbociclib, the CDK4/6 inhibitor, with letrozole. And what we see is in this relatively small study that there was a statistically significant improvement in hazard ratio for the primary endpoint of progression-free survival, with a median PFS from 3 months versus 8.3 months. And the disease control rate was also higher in the combination group. So that's really interesting results that should be explored, I think, further in larger clinical trials. And what about HER2-directed therapy? Well, this slide summarizes a randomized phase 2 study of carboplatin and paclitaxel versus the chemotherapy with trastuzumab in uterine serous carcinoma overexpressing HER2. And HER2 overexpression does confer a poor prognosis in endometrial cancer, and the addition of trastuzumab to chemotherapy was shown to improve both PFS and overall survival. So in a subset analysis of patients restricted to stage 3C and 4 disease, the addition of trastuzumab, as you can see, helped with a hazard ratio of 0.44. So 21.1 versus 31.9 months in terms of overall survival benefit. And more recently at ASCO last year, looking at pertuzumab plus trastuzumab in uterine cancers with ERBB2 or ERBB3 amplification. These are results of the TAPUR study. And these are patients that had previous treatment. The overall response rate was around 7%, and the disease control rate, including stable disease at more than 16 weeks, was somewhat higher at around 37%. And bearing in mind that over 50% of women had 3 or more prior lines of treatment. So again, an area for further investigation. Now for the remainder of the talk, I'm going to move on to immunotherapy. There's a strong rationale for immunotherapy in microsatellite unstable or MSI high endometrial cancer. These cancers have an increased neoantigen load, more tumor infiltrating lymphocytes, and higher PD-1, PD-L1 expression. So I'm first going to summarize the KEYNOTE-028 study, which was of pembrolizumab in PD-L1 positive endometrial cancer cohort. This is an open label phase 1b study in patients with recurrent PD-L1 positive endometrial cancer. And patients were treated with pembrolizumab every 2 weeks. So here is the spider plot of responses here. And PD-L1 expression isn't a sufficient biomarker to identify patients who respond to treatment. There were 3 responses, as you can see. One was poly-ultra mutated, one was non-MSI high, one was MSI unknown. And this was published in JCO back in 2017. And then when we look closer, based on increased numbers of patients with pembrolizumab in MSI high endometrial cancer, we see an objective response rate of around 36%. And this led to the FDA approval in May 2017, an accelerated approval for FDA for patients with metastatic MSI high or MMR deficient solid tumors. And this included endometrial cancers. So more recently, a couple of weeks ago, in the Journal of Clinical Oncology, the MSI high endometrial carcinoma pure group was published with Pembalizumab. And what you see here is an overall response rate of 48%. There were some patients that had a complete response, so 14%, and the PR was 34%. The median duration of response was not reached. The median PFS was 13.1 months, and the median OS is not reached. So I think this is very exciting news. And then another PD-1 inhibitor, dostarlimab, investigated in the Garnet study. So I'm not going to go through the entire drug design in the interest of time, but I'll refer you to the endometrial cancer cohort publication of ours in JAMA Oncology, published in 2020. So what we know within the Garnet study is that the overall response was 44.7% in dMMR endometrial cancer and 13% in MMR proficient endometrial cancer. I'd like to take this opportunity to talk about immune-related adverse events, because it's really important now for oncologists treating gynecological cancers. So these events can occur in any system of the body. So skin, GI tract, endocrine, and lung is the most common. And looking at the safety profile in the dostarlimab Garnet study, we saw that in terms of treatment emergent adverse events, this was around 50%. Treatment-related serious adverse events, just under 9%. And the most common include diarrhea, hypothyroidism, and an ALT increase. When we look more further at the treatment-related adverse events across different tumor types, and we looked at that within the Garnet study, the majority are low grade. 7% experience grade 3 immune-related treatment-related adverse events, and they were spread across all systems. 9.7% were immune-mediated endocrinopathies. Importantly, when the dose schedule changed from 3-weekly to 6-weekly dostarlimab, there was no spike in the rate of adverse events. Now I'm going to talk about the practice-changing Keynote 775. This is a phase 3 randomized study that, again, I was honored to be an investigator in, along with the Garnet study, recruiting patients. And this study was in advanced metastatic endometrial cancer. Patients had 1 prior platinum-based therapy and were randomized to Lenvatinib and Pembalizumab or standard of care chemotherapy, so doxorubicin or paclitaxel. Here is a summary of the progression-free survival that was presented initially for the MMR proficient and all-comers group. And we see these Kaplan-Meier curves showing an improvement in PFS in MMR proficient and all-comers, with hazard ratios of around 0.6 and 0.56, something we have not seen in recurrent endometrial cancer for a very long time. And now looking at overall survival in the same group of patients, again, a statistically significant and meaningful improvement in overall survival with hazard ratios of 0.68. So median improvement from 12 months to 17.4 months in the MMR proficient group, for example. We presented sub-analyses of this group, the PFS according to histology in all comers, looking at endometrioid, serous, and clear cell. And across these subtypes, we see a substantial improvement with Lenvatinib and Pembrolizumab compared to standard of care chemotherapy. This is very notable in the clear cell histology subtypes, which, as you know, are notoriously difficult to treat. And similarly, signals in overall survival, hazard ratios ranging from 0.65 to 0.33 in the clear cell group. Small numbers, but signals of activity in these rarer subtypes. Similarly, we looked at prior therapy and platinum-free interval, and as you can see, the majority of these groups actually benefited irrespective of platinum-free interval and prior therapy. Now focusing on the MMR deficient group, this was more recently presented, looking at the progression-free survival. This was 3.7 months with standard of care chemotherapy versus 10.7 months with the combination of Lenvatinib and Pembrolizumab. The overall survival curves are shown here, and the median is not reached. In terms of response rates, the objective response rate was 40% versus 12% with chemotherapy. And the toxicity profile is important to acknowledge. Lenvatinib can cause diarrhea, and dose reductions and modifications are required. And I hope I'm invited another time to talk about how we manage these side effects in practice. Here we see in a bit more detail the Lenvatinib and Pembrolizumab response rates and median duration of response according to pMMR groups and all comers. So again, substantial improvements seen compared to chemotherapy, and notable durations of response, and responses occur. As I mentioned, some of the side effects, which I know looks quite busy here, but important to note, with Lenvatinib, which is an anti-angiogenic agent, hypertension can occur. We need to look for hypothyroidism, for example, and diarrhea. I'm going to end in the last minute looking at the ongoing first-line phase 3 trials. Here are some examples. There's the ENGOT-EN7 study, a phase 3 double-blind randomized placebo-controlled trial of atezolizumab in combination with carbotaxol in advanced recurrent endometrial cancer. So that's ATTEND. There's another study of carboplatin and paclitaxel versus carboplatin, paclitaxel, and pembrolizumab. The RUBY study, again, a phase 3 randomized double-blind study of dostarlimab, this time with carboplatin and paclitaxel, followed by dostarlimab and niraparib, the PARP inhibitor, versus placebo. So very interesting question about immunotherapy and PARP inhibitors. There's the DUO-E study, which is durvalumab and olaparib in endometrial cancer. And so as you can see, the theme of immunotherapy and targeted therapies, either in recurrent disease or bringing them forward into the first-line setting. So finally, to end with, these are the drug approvals to date in endometrial cancer. I mentioned and showed you the data which led to the FDA approval of pembrolizumab. This was the first tissue agnostic indication according to MSI high or DMMR status. With dostarlimab, the EMA conditional marketing authorization was in April 2021, and the FDA accelerated approval was in August 2021. So 2 immunotherapy PD-1 inhibitors approved, and then in addition, based on the Lenvatinib and Pembrolizumab study that was recently published in the New England Journal of Medicine, FDA approval in July 2021. And this was for patients which did not have MSI high or mismatch repair deficient tumors. So to end in with, I hope I've shown you that we're in an era of treatment progress in endometrial cancer. Immunotherapy is changing the standard of care. We need to improve outcomes for rare histological and molecular subtypes, for example, clear cell, and also certain molecular subtypes like the RAS mutated, which includes endometrioid carcinomas. Our future is about bringing immunotherapy earlier on in the treatment pathway and developing therapies beyond immunotherapy, for example, HER2, CDK4/6 inhibitors, and the PIK3CA pathway. Thank you for your attention.
Thank you, Dr. Susana Banerjee. That was a great talk, and compressing the whole treatment paradigm change in endometrial cancer in 15 minutes. That was really great. I have a few questions to ask you. Coming to the HER2 positive endometrial cancers, in the second line, you mentioned about the data on pertuzumab and trastuzumab. How about the newer drugs like TDM1 and the Durexican? Have they shown some activity?
I'm very glad that you've asked that question, because that is the new generation of HER2-directed therapies. So there are increasing number of trials looking at this and including cohorts for women with gynecological cancers. So at the Royal Marsden, for example, we are one of the sites recruiting to the Destiny trial, which is from AstraZeneca, looking at the agent you mentioned. This includes a cohort of endometrial cancer, as well as cervical cancer and other cancers. So I'm really interested to look at the results of those.
Well, the second question I wanted to ask you was regarding immunotherapy. As you know, that pembrolizumab is now approved for MSI high tumors. The study also included those who had a promoter methylation of MLH1. So when you actually give immunotherapy to these patients, in practice, would you also include these with the promoter methylation?
It's really interesting you should ask that, because it's also about how one tests. So, for example, in the UK, what we've been trying to do, so that this is more practical and standard of care practice, is use immunohistochemistry. So we're looking at IHC, which obviously doesn't tell us about the mechanism of protein loss. And within these clinical trials, for example, the Garnet study, the entry criteria didn't specify the type of mechanism. And so at the moment, and that's why the licenses are as they are, and looking at IHC, for example, or if then they've had genetic testing to actually identify that they're microsatellite high and stability high.
So the next question is that, you have such good results with Lenvatinib and Pembrolizumab, as well as Pembrolizumab in the MSI high tumors. So in fact, the hazard ratios are much better with the combination. So I know that it's not approved for MSI high tumors. It's mainly for those which are, not MS stable. So what is your take on this, that you have a better treatment even for the MSI high, but, it's only for the MSS?
So I think when we're choosing treatments for our patients, it's also, we need to balance side effects as well, and when to use drugs at what point in the pathway. So the Keynote 775, the Lenvatinib, Pembro and chemotherapy trial, is excellent because it's a randomized phase 3, whereas the studies I presented to you, which led to Pembrolizumab approval alone, or indeed the Dostarlimab, are early phase studies, and based on the clinical results, basically response and duration of response, this is what led to the approvals. So, but what I really like about the Keynote 775 is the breakdown according to, as you've highlighted, MMR deficiency status. And when we look at the response rate, though, in terms of the Lenvatinib Pembrolizumab, it was 40%, the objective response rate. So complete response was around 13, partial response 26.2. So similar ballpark to what I'm saying with Pembrolizumab alone, or indeed Dostarlimab alone, which was above 40%, 45 to 48%. So if one drug can achieve that, why use two in that molecular subgroup? We need to think about clinical trial sequencing therapy. Can we re-challenge with immunotherapy, Pembrolizumab, for example, in the future, and perhaps add Lenvatinib then? Now, some of these studies, like the LEAP study, is bringing that Lenvatinib and Pembrolizumab question earlier on as the first-line treatment. And so that would be really interesting to see. We need to see what local approvals are like in our individual countries as well, beyond the FDA approval.
Thank you so much.
Thank you. I hope to be in India at some point.
Yeah, looking forward to that. Thank you.
Thank you.